Good morning, good morning, good morning, Naki. How are you?
Good morning, Dr. Samoa.
Good morning.
So, good morning, everybody. And this is a special broadcast, but it is something that is of a high priority that Dr. Samoa expressed a concern that we need to get the communication out to the community as quickly as possible. So we have a show with 3 different segments that we're going to run through, highly sensitive and important information to go over. So, Naki, I'll turn it over to you and we can get started.
Awesome. Thank you so much, Carl. Dr. Samoa got a hold of us a few months ago, like yesterday. And we have this webinar, like Carl said, to just go over health disparities in cancer, diabetes, and crystal meth use in Samoans living in California, Mai Samoa I Kalifornia. We have the researchers panel. We have sector experts panel, community leaders panel. We have a bunch of great information. Please stick around, share this with everyone that you know, and we'll hand it over to you, Dr. Samoa.
Sure. So around November, we had a discussion with some community leaders just to prepare for like new administration and what to get ready for. And there was an overall frustration with kind of the state of health. You know, people kind of getting tired of going to funerals and just, you know, seeing people ill, where they didn't see it in a lot of other kind of communities. And so they identified 3 health priorities. 1 was cancer, 2 was diabetes, and 3 was actually ice or crystal meth use. And so based on that, we sought out to seek out researchers, health experts, to try to figure out what's going on. And so we were able to sort of successfully find a great deal of information about the Samoan communities living in California. And so we thought, hey, what better way to sort of push that news out and sort of sound the alarms through a podcast. And, you know, I know no better podcast to reach like Pacific Island communities, especially Samoan communities, through the FICA podcast. And hence, you know, why I'm here with Naki and Carl on a Saturday morning wearing my serious glasses, so we can get started. Yeah. So I'm excited to see what everyone has to say on this.
Awesome. I think so. We're going to start with the researchers panel. Naki, you want to get started with our first panel expert, and I'll start bringing people on stage.
Naki, you're muted.
Sorry about that, folks. Okay, so with the research panel, we have Andy Subika, is a professor of social medicine, population and public health in the University of California, Riverside School of Medicine. His research addresses mental health and substance use challenges affecting Pacific Islander and other underserved communities. Welcome, Andy.
Next, we have Dr. Kekoa Tapara. Dr. Kekoa is a board-certified physician and tenure-track assistant professor at UCLA, where he serves in radiation oncology and health policy and management. At UCLA Health, he specializes in treating prostate and other genitourinary cancers. Born and raised in Hawaii, Dr. Tapara is deeply committed to Pacifica communities and to improving cancer care for families impacted by cancer. His own family's experience with cancer motivates him to care for patients with compassion, dignity, and aloha. He trained in radiation oncology at Stanford University and earned advanced degrees in medicine, public health, and cancer biology from Mayo Clinic, Hawaii Pacific University, and Johns Hopkins University. As a physician scientist, he connects patient care, cancer research, and public health to improvement outcomes across the cancer care journey. He has co-authored more than 90 peer-reviewed publications in leading medical journals and has received national awards and research support from major cancer and medical societies. Welcome, Dr. Kekoa.
Awesome. And next, we have Brittany and Maury, PhD, MPH, is an associate professor in the Department of Health, Society, and Behavior at University of California, Irvine, Joe C. Wen School of Population and Public Health. She received her MPH and PhD in Community Health Sciences from UCLA. Dr. Maury's research focuses on how structured factors shape racial and ethnic health inequities, including how neighborhoods affect cancer outcomes for minoritized groups. In 2024, she partnered with Native Hawaiian and Pacific Islander organizations throughout California to lead the California Pacific Islander Wellbeing and COVID-19 Economic Survey. She has published over 50 peer-reviewed articles on topics related to addressing health inequities. Welcome, Dr. Maury.
And we have Jake Pitise Manu. Jake was born.
Oh wait, that's
It's not on here.
wrong panel.
Yeah, wrong panel.
Oh, we're good.
Yeah, we're good.
Okay.
So before we start, I think as is Samoan protocol, and this panel is included as well. Please mention your parents' names and where your parents are from. Yeah. And so I think why don't we start with Andy? Yeah.
Okay. Am I going first with the presentation too? Okay. All right. Hello, everyone. Thank you, Carl, Naki, Dr. Samoa, for allowing me to speak to you. And thank you, everybody, for attending this thing. So my name is Andy. My father's name is Alan Subika, and we're originally from Kurtistown on the Big Island of Hawaii. It's a sugarcane plantation town, and my mom's Aiko Subika from Oita, which is the countryside of Japan. And so I'm a clinical psychologist, born and raised on the Big Island, and the Big Island's actually the place that's suffering probably for the longest time since I've been working, one of the strongest ice epidemics in the US. And so this is obviously something near and dear to my heart. Let me try and share my thing. So apologies to everybody.
No
My
worries.
first time using this StreamYard. So this is
Yeah,
kind of
no
cool.
worries. No worries.
Okay. Tell me, can people see this one?
I'm going to pop it up.
I actually don't look like I have the option. You might have to allow me to share. Oh, okay, wait here.
You always have to go into that presentation screen.
There we
Yeah.
go. All right, can people see this?
Second.
Yeah.
There you go.
There
All
we
right, cool. Okay. Yeah, so this is just really quick talking about Meth Pacific Islanders. It's only going to be a couple 7 minutes, but I'll try and go through this quickly to leave time for, the real superstars on this panel. So what is meth? So people probably have heard about meth for a long time. It's actually a lab-made drug. So it's a synthetic drug that speeds up the brain and nervous system when you take it, and it produces an intense high. That's one of the reasons it's such a big problem, because it creates this intense high that can last for hours. And in most places in the US, Hawaii, here in California, it's really mostly about crystal meth, what we call ice, because it's very cheap, it's very easy to make, and it's easy to buy. So people have probably heard of ice. And when you think about ice, it's this glass-like or blue rocks. And you got to either smoke it with a pipe or you inject it, and it gives an immediate high. I grew up hearing about it as batu. And then there's another form called speed crank, which is a little bit less strong, and it's in powder forms. So this is really what you would see here, like in California. This is ice, and it's mostly smoked through pipes. So what makes ice such a powerful but dangerous thing? What it does is, as soon as you take ice, it hits your brain with a bunch of what we call dopamine, which is the pleasure hormone that your brain automatically makes every time you feel good. So if you're eating something really good, you're having, some fun, you're going to get natural dopamine, but meth just hits your brain with so much dopamine. It's more than almost anything you get naturally or any other drug. And the high lasts for a long time, about 8 to 12 hours. And that's incredibly long high compared to stuff like cocaine, heroin, where you get 1 to 2 hours of a high. So you can understand why people use ice so much. The problem with ice is the brain is really good at adapting to almost anything, even a poison like meth. And so if people use meth, eventually, pretty quickly, your brain stops making its own natural pleasure drug, the dopamine. And so what happens is people who actually use meth, they need to keep using meth just to feel normal, just to feel the same way they used to feel before they started using. And it's really hard to get out of meth use, meth addiction, because you can stop for years or decades and still get cravings. If you smell something, you're back in a situation that reminds you of it. So it can take a long time to quit, and it's cheap and easy to get. So why am I really talking about why meth is so powerful? And I know I'm talking pretty quick because I want to make sure to leave some time. But the key here is when you start using meth, when somebody starts using it and they get addicted, it's not because they're weak. It's not because they don't have willpower. The drug has actually changed the way that the brain works on a biological level. And so people need to start using meth just to feel normal, just to feel anything. And you can see it here. If you look on the left side and you see the brain lit up, that's what it looks like with a normal brain when you eat something or you're doing something fun, the brain lights up. You look on the right side after someone's been using meth for a while and you see that the brain no longer lights up as much. And that's because the brain has just adapted already. And so this is what just happens when people use meth. So what really happens in the real world? It's really dangerous because it damages the heart and the blood. So you see a lot of ER, you see a lot of stroke, a lot of heart disease and death. It also damages the brain, as you saw. And so it affects decision making, impulse control, it creates aggression, irritability. And this is why when people have been using it for a while, they actually stop making good decisions because the brain has started to get damaged. You also see that people start talking to themselves, they get very paranoid because it also messes with the brain in that way. You see increase in things like violence, but here's what we really see when it comes to meth, when it comes to like Pacific Islander communities is it leads to a lot of incarceration. I've worked in kind of prison settings and saw a lot of ICE. I work with unhoused communities, Native Hawaiian Pacific Islander, and you see a lot of meth there. But more fundamentally, meth and ICE really affects the family. It really tears apart families all the time. And then you see trauma and chronic disease. I'll probably skip this pretty quick, except to say that meth is dangerous. It's either the first or second leading cause of overdose deaths, drug deaths in California, Hawaii, Washington, Utah, basically any state that has Pacific Islander populations, meth is either the first or second leading cause of death when it comes to drugs. Specifically, when you look at what's been going on for Pacific Islanders in California, there was a long ICE crisis in Hawaii, but it's now shifted to California. So some of our research is looking at that. But the problem, and you're going to see this later in the other researchers' talk, is Pacific Islander data is always mixed with Asian American data. So here in California, you can't get Native Hawaiian Pacific Islander drug use data, substance use data. It's pretty much always mixed with Asian American data. And every time I've worked with a lot of people who've had ICE use, Pacific Islanders, and they always talk about how it's had this multi-generational effect. So if somebody uses, it's not just on them, it's on their family and children. And I'm just going to kind of go through what can people do if you see somebody who has meth use, someone in your family, friend, someone in the congregation. Number one is you want to start with love, not judgment or confrontation, which is very hard to do if you work with someone who's been using ICE. But the addiction is a medical disease. And so making people who are using feel shame or fear is actually closing them up and making it harder for them to open up to get help. So saying something like, I love you, I'm worried about you, I'm here, it just hits different than saying, what most of us would want to say, even as a psychologist, you have a problem, you can fix it. That's usually going to close people up. Understand how meth works, where it really is harming the brain and creating paranoia. So if you're engaging with somebody who has ice use and they're high, you're arguing with the drug, not the person. And that can be very hard to feel in that moment. You want to hold limits and safety without cutting people off. And what this means is you want to set firm limits to protect the family without, don't give money, don't live in the home, don't allow them to live in the home while using, even if you care about them. But you also don't want to cut them off completely if you can not. Loving someone who is using meth doesn't mean you have to accept everything they do, but also doesn't mean cutting them off completely. I have a little bit more, but I want to kind of end there and leave some time for the other people on the panel.
Sure. Can we ask a quick question before we move on to the next topic? So, a lot of your publications deal with mental health in Native Hawaiian and Pacific Islanders. And then, since we're kind of focusing on Samoans in California, and you've done, you've published in mental health in like Samoan and Marshallese communities in California, and Arkansas. What do you think are the mental health contributions to this sort of ICE pandemic in Samoan communities?
Oh, yeah. One of them is trauma, for sure. And that's like cultural, historical trauma, just the trauma passed down by generations. Then it's also the interpersonal trauma, which means the trauma not on the communities, but that people experience in the home, in their neighborhood. Hear that a lot growing up, is they go through a lot. And then the other part is just stress. And I think that's going to come up a lot, is Pacific Islander communities are always stressed, especially younger people. They feel so much stress. I hear this all the time in Carson, Long Beach, all across California. And that can be from family pressures. It can be from just the environment, can be from school, work. And those stresses can get people on this path of using alcohol to deal with stress and then using other things. And eventually, because ice is so easy to get and it gives you such a big high that before you know it, you're addicted, and then your brain no longer is able to stop because it is rewiring the brain. So it's kind of this thing of stress. And we just don't talk about stress enough.
Yeah, I can see how generational communication obstacles can kind of lead to like worsen this. Because it's Pride Month, can I ask, like, how does cutie pies kind of factor into this?
Oof, okay, so we've done a good amount of research with cutie pies, and unfortunately, it's the stress, the cultural identity, all these other things are magnified for these individuals. So we actually find that the meth use and the illegal substances, illicit substances, meth is, I think, 4 to 5 times more in cutie pie communities than it is in even Pacific Islander communities. And I didn't really even talk about stats, but in Pacific Islander communities, it's like 2 to 3 times higher than for white people, right? Like other people. So it's just a profound level of just stress leading, I think, to trying to use things to feel better. And meth really does do that to some if you first start using it. Mm-hmm.
All right, stick around because I'm sure we have more questions for the entirety of the panel after. Yeah. All right, let's move on to cancer. So I do want to say, like, Brittany actually sounded this alarm. I can't remember, Brittany. Was it like October, July, something like that in 2025? And so thank you so much for bringing this to our attention. It's so much so that I think it kind of like it matched up with what the community was saying was a problem. So, this is a really good way of seeing how, academia and community can better sort of like communicate and help improve things that they're experiencing. So, Brittany, don't forget your parents and where they're from, and then you can go right into your presentation.
Okay, great. Thank you so much, Dr. Samoa, for having me here, for inviting me and collaborating with me on this research. So my parents are Dr. Francis Wong and Debbie Wong. They are on my dad's side. Both sides actually are descendants from China, from the Guangdong province, and my dad, having his parents immigrated to here from um, during a time of the Chinese Exclusion Act, so wasn't able to live here, settled in Mexico, ended up eventually moving here to Southern California. On my mother's side, my great-grandparents immigrated here from China. So I just want to, first recognize that as one of the few non Pacific Islander, non-Samoan people here on the panels today, that I'm deeply honored and also humbled to be among such esteemed colleagues. And I'm not here just to present research, but also to listen and to learn from from the communities here and to see how you all might be connecting or relating to the different research that we're presenting today. Is someone able to show my slides? Great, thank you. So today I'm going to be talking about cancer mortality disparities for Samoan populations. Next slide, please. And I know that mortality and cancer, these are heavy topics, but I want to flip the narrative a little bit and focus on this aspect of longevity, right? So it's not just about, death and death rates, but it's also about how do we make sure that Samoan community members are able to live lives that are full and long and are able to pass down their knowledge to their children, to their grandchildren, to be able to, see them growing up and carrying on the baton. How are we able to make sure that people as they age are also living high quality life, right? Free of disease. And so I want to think about that as I'm talking, not just mortality, but also longevity. And so in order to talk about that, we need to talk about what are those leading causes of premature death, in Samoan populations. And for Samoans in the United States, it's very much the same as other Native Hawaiian and Pacific Islander groups. And it's also mirrors that of the total US population, which is that the number one leading cause of death is heart disease, but the second leading cause of death is cancer. And so I commend, the community members for identifying from their own experience that these are, big issues in the community. Next slide, please. So what are the common cancers? So for Samoans in the United States, this is data from the American Cancer Society. For female Samoans, the top cancers, number one is breast cancer, followed by uterine cancer, lung cancer, and then colon and rectum cancer, or colorectal cancer, as we call it for short. For male Samoans, the top cancers are prostate cancer, lung cancer, colon and rectum cancer, and stomach cancer. Next slide, please. So we do see that there are disparities in mortality or in death for Native Hawaiians and Pacific Islanders. Again, this is American Cancer Society data. And so in these bars, you'll see the dark green bar on the left. These are Asian American mortality rates. On the right is the blue bar, that's the white US population mortality rates for cancer. And then the middle bar, the light green bar, that's for Native Hawaiians and Pacific Islanders. And you can see here in all the boxes, the orange ones that I highlighted, these are all the ones where the mortality rate or the death rate is higher for Native Hawaiians and Pacific Islanders. And so in this graph, you'll see breast cancer, liver cancer, stomach cancer, uterine cancer, and cervical cancer. These are all cancers for which Native Hawaiians and Pacific Islanders are dying earlier and at a higher rate. Next slide, please. So that now brings me to the research that we've been doing in collaboration with Dr. Tapara and Dr. Samoa here on this panel. And so this is to look at disaggregated cancer mortality risk for the NHPI groups and comparing it to non-NHPIs. And so in this graph, these curves represent death rates. And so this higher the curve, the steeper the curve, the sooner people are dying when they are diagnosed with cancer. And so in this graph, the dark blue line is the second to bottom line. That's non-NHPIs. And then the Samoan line, that's the orange line. So the top line you'll see here is for Samoans who have cancer. And so you'll see from this graph that this is data from California. Anyone diagnosed between 1998 and 2022, that Samoan communities are dying from cancer at a faster rate, at a higher rate compared to non-NHPIs. Next slide, please. So now I'm going to focus in on certain types of cancer and talk about what we can do about this. And so these slides represent breast cancer mortality for Samoan women. And so on the left hand, you'll see that even after we account for things like age and socioeconomic status and people's health insurance, that Samoan females are dying from breast cancer at twice the rate as non-NHPIs. And so the blue line, the bottom line, that's non-NHPIs, and then the top red line, the red line now represents Samoans. Now, on the right-hand side, when we include in our modeling cancer stage of diagnosis and cancer treatment, this gap, there still is a gap, so Samoan females are still dying at a slightly higher rate, but this gap is lessened. So what does this mean? So this means that if we could have Samoan females get screened and staged and at an earlier stage of diagnosis at the same rate as non-NHPI females, and if we can get them the treatment that's the same level as non-NHPI females, then we can lessen this gap between Samoan females and non-Samoan females. Okay, next slide. And it's the same story for other cancers that are common among Samoans as well. So this shows colorectal cancer mortality. Again, on the left-hand side, we see this pretty large gap between Samoan and then non-NHPIs. But on the right-hand side, if we were to get people staged earlier and also the appropriate treatment, this gap basically goes away. The curves are almost exactly the same. And so this is actually very positive news to me. To me, this indicates that there is something that we could act upon. There's something that we could do to reduce this gap in mortality for Samoan communities. Next slide. Okay, so that brings me to what you can do for your family, for yourself, to increase longevity. First of all is to get screened. See your doctor regularly, and also ask your healthcare provider about the right screening tests for you and your loved ones. Again, if we could get people screened and diagnosed earlier, this can help to reduce the gap. And the second thing is to seek treatment. If you and your loved one or your loved one is diagnosed with cancer, listen to your doctor's advice and seek treatment from an oncologist, a cancer specialist, right away. Doing these two things, screened and seeking treatment, can help to reduce the gap. And then also, practice healthy habits, eating a healthy diet with lots of vegetables and fruits, and being physically active to maintain a healthy weight. These things not only prevent cancer, but it also could prevent death from cancer. And then lastly, quit smoking. If you or a family member smokes, encourage them to quit, and also try to avoid being around secondhand smoke. Smoking is still the #1 leading cause of cancer and cancer death. Next slide. So again, I want to, here's my email if you have any questions. I want to recognize my collaborators, Dr. Kekoa Tapara, who will be speaking next, and Dr. Mai Samoa. And I want to say, Fa'a Fitai Telelava, thank you very much for having me here and being able to present to you today.
Thank you so much, Dr. Lori.
Oh, that was awesome.
That was
well,
I learned
not
so
awesome to
much.
hear, but it was good to finally get that information. And so, yeah, there's I'm sure that, Naki and Carl and myself have a ton of questions. So we'll wait till after Kekoa presents to kind of ask the panel as a whole. Kanaka, Dr. Tapara, would you like to present next?
Yeah, absolutely.
Don't forget your parents and where they're from. Yeah.
Yeah, I have it on my slides if it could bring it. Of course. Aloha mai kako, talofa. I'm really excited to be here today to talk about, continuing to talk about cancer, but I always put this up front. You know, I am Kanaka-Iwi, so not Samoan, but my ancestors come from the Aina of Maui, Kauai, and Oahu. I honor my father's lineage, Tony Tapara, the Taparas, Sarsh, Akana, Uuma, and Kalima ancestral lines, from which they come from Kauai. And I honor my mother, Judy Wong Tapara. She's from the Wong, Aki, Kamaka, Kuli'i, and Kekaulike lineages of Maui. And I also want to take the time to acknowledge our queen who abdicated her throne to protect the people of our island of Hawaii. I recognize Hawaii remains an occupied state of America, and I recognize it's my kuleana to uplift the health of our lahui and our Pacifica communities, including our Samoan brothers and sisters as well. Just a little disclosure, although I'm Kanaka-Iwi, Native Hawaiian, I represent myself and not all the lahui. I recognize we have a diversity of thought, and I bring my own experiences to this presentation today. But yeah, and as a way of background, I'm from Oahu, so that's where I was born and raised. I mentioned my mother and father's lineages, but they raised me in Mililani up in the mountains of Oahu. And as I've said, they're both Native Hawaiians, so they sent me to the Kamehameha schools, which is a school founded by one of the last princesses of our monarchy, Princess Bernice Pauahi Bishop, who, as a Native Hawaiian dying from breast cancer, really wanted to put all her funds and trust into developing a school for Native Hawaiians. And so at Kamehameha, that's where we learned about, you know, Pacifica and also Native Hawaiian language, tradition, culture, heritage. And I bring with that I bring that information and context into the research that I do today. Also, while growing up, I also had 12 family members with cancer, and I watched many of them pass away. I think only one of my family members who has had cancer is alive today. And I think whether it was prostate cancer, breast cancer, endometrial cancer, lung cancer, even pediatric neuroblastoma, you know, I saw many of my family members within our community and members of my community pass away from cancer. And so really inspired me to be interested in this field and some of the work that I'll be sharing with you today. My educational background, I went all the way from Hawaii to Connecticut and was freezing cold, but I swam, and that's the only way I got to college. But, you know, I met a lot of the first academics, you know, first PhDs I ever met was in college, and they inspired me to go and do science training. So they told me to go do my PhD, and I went to Hopkins for my PhD and met the first real physician I ever really talked to in my life, Dr. Tran. He was my PhD advisor, and he was the one who, you know, took me to the clinic and inspired me. He let me watch him talk to patients, and I saw him and heard him say, you know, we can go for cure for prostate cancer. And I was like, oh, I had 6 uncles with prostate cancer and 5 of them died. I didn't know you could cure this thing. And so he inspired me then to go to medical school. And that's when I went to Mayo Clinic for medical school, where I started learning more about cancer. I went to Stanford for residency, and during residency, I completed my master's in public health at Hawaii Pacific University. And so, you know, as much as I bring with me my ohana and my kupuna that came before me from my family as well, I also bring with me my academic folks and mentors who've brought me to where I am today as well. And so now I'm at UCLA. I treat patients in the clinic here at UCLA, and then I teach in the School of Public Health as well. I have a lab. Actually, one of the very first students I had was Samoan, and my current research student is Samoan as well. So they're around and proud and teaching me all kinds of things here in this lab that I have, about 30, 40 students at any given point in time. But what we really focus on as predominantly Pacific Islanders, including Samoans in our lab, we use that information of how we grew up and the context of which we were raised to help contextualize the data that we are able to produce with some of the scientific research studies that we have. And this is some of them that we've published. We work on Indigenous data, space, climate health, and health policy. And so for the talk today, Dr. Mori set me up perfectly to, talk about the cancer statistics that we have. And so I'll be talking about that a little bit further in terms of why it's important to include data, like Dr. Mori did, talk about the specifics of data and not just kind of mortality statistics, but kind of why do those things happen for some members of our community. And then I'll talk at the end about clinical trials and why it's really important to be familiar with what a clinical trial is, so that we can have representation for Samoan communities and other Pacific Islanders as well into these trials to help inform the next generation of cancer care. And so just starting with some data, the reason why I think, Samoans and other Pacific Islanders are really forgotten is because when we just look at a world map and we just Google world map, you can see that it's very Africa, Asia, European centric. And we always quite literally are splitting our Pacifica communities, and so that we don't have the attention that we deserve. So our group's focus really, again, is to help reshift, reframe the Pacific so we can be thinking about Samoan communities. We can think about, our Pacifica Islander brothers and sisters as well. And so when we think about the definition of even Pacific Islander in the context of data, we look at legal definitions. And so when we think about the definition of when it came in, for Native Hawaiian in public law, U.S. Public Law 103-150 in 1993 was first passed. This is the Apology Bill. It was the first, one of the first times where we put a definition of, okay, Native Hawaiians were those who, in the Aboriginal people prior to 1778, were exercising sovereignty in this area that's now the state of Hawaii. And Senator Akaka passed this bill with the Senate and House of Representatives in this joint resolution. And so that was 1993. And then in 1997, a few short years later, we see for the first time, like Dr. Mori said, this importance of the disaggregation of Asian and Pacific Islanders. So in 1997, over a quarter century ago, we have Native Hawaiians or the Pacific Islanders pop up as one of the checkboxes for data. And again, you need the checkbox in order to even evaluate the data. And that's true for even just the Samoan checkbox as well. And so that developed over time. And the reason why that's so important in healthcare research and why it's important to include this data is because the Affordable Care Act, Section 4302, it mandated that we have to include these Pacifica checkboxes because they went with this 1997 classification. So the Native Hawaiian Pacific Islander population have to be included legally as mandated in these federally funded researches. But what we know, from Dr. Mori's research and Dr. Nunez Ponce here at UCLA and others is that, especially during the COVID era, it became very apparent that we were not doing this. 20 of the 50 states were reporting it. So less than half of the states were even reporting Pacifica data. And what was most concerning is that when we looked at, when they looked at, who was dying the most of the 20 states that were reporting Pacific Islander, is the majority, 18 of the 20 were actually showing that Pacifica were dying of COVID at the highest rates. And that was, something that we see in our data. This is a publication from Dr. Faust, my collaborator at Harvard, where we published looking at the different ages. And what was most concerning is that really young people in the United States were dying from COVID. And again, we never would have seen this unless Dr. Faust and his team included us and disaggregated and included, according to federal guidelines, the Pacifica community. And so when we have this data, we can recognize that, the young people in the United States that were dying at the highest rates of COVID were the Pacifica community. And so the impact of that data and including the data, I have to stress, is so important because it translates to our communities. And when we don't have the data, it's lost upon our communities. And so this was very true during the COVID era, where, after data was coming out, people were interviewed, including folks in Long Beach and all over LA, including Samoan communities, where people were saying, like, I was naive to think that this couldn't touch my ohana. I couldn't touch my family. Because the reason why, I think, is, if it's in the media and it's a lot of attention. When I was going, I was a resident at the time, new intern, treating all these people who are dying from COVID. And, you know, I saw on the news all the time after my shifts, I would see Black and, you know, Latino communities, but I didn't see anything about the impact of COVID on our Pacifica communities. And so, you know, my uncle, when he was in Riverside, he had a little bit of a cough, checked in with his primary care. They didn't get a COVID swab, didn't think it could be COVID. And then it got worse over the course of the week. And then he, you know, ended up having to get checked into the hospital, still didn't get a COVID test, but then eventually he did. It was positive, you know, very short after he was on a ventilator and died. So he didn't even make it out of the Riverside Hospital. And so that was just, again, an important point of like, this was impacting our Pacifica communities really closely. And again, the importance of, if you don't see the data, then we have no way to really realize that we need to put certain resources in certain parts of our community. And so that's why inclusion of Samoan data, inclusion of our Pacifica data is so important to see this, not just from a pure research standpoint, but also from advocacy and policy, and so that we can get community members involved and engaged and knowledgeable about what's going on in terms of our health. And so, summary of first point, omission of our community's data not only hides the truth, but it does also have real world consequences. Okay, so moving from the importance of this data and inclusion, let's talk a little bit more, building on what Dr. Mori had already talked about. The reason why I'm interested in cancer data, again, is because of the 12 family members that I've had with cancer that I've watched die over and over again. And that's not just me, it was also all my, you know, friends growing up, like Native Hawaiians, our communities, you know, had a lot of people who had cancer and were dying from cancer. And actually, when I was in medical school, the first Pacifica patient that I ever interacted with was Samoan when I was at Mayo Clinic. And so, you know, where it's not just a Hawaii thing, it's not just a California thing, this is throughout the country we exist. And we have to understand that, you know, when I was a medical student, I was reading these papers and over again, they said that Pacific Islanders have really good outcomes or superior survival outcomes across all of these different race categories. And I never really understood why that could be when so many of my family members and the, you know, patients that I was seeing in the hospital who were Pacifica, including Samoan, they weren't doing very well. And so that's why, you know, many years ago, I collaborated for the first time with Dr. Fumiko Chino. She was at Memorial Sloan Kettering, which is an incredible cancer hospital. And, you know, this was one of the first publications that I did in breast cancer, where normally this is a single line where it's like Asians and Pacific Islanders are doing really well here in breast cancer overall survival. But when we take apart things like East, South, Southeast Asian even and disaggregate it a little bit further, meaning that when we look at all these different Asian groups, they're kind of all still the same. But the difference was when we took out also the Pacific Islander community and looked at them, it was different. And that was something that really wasn't seen, at least using this data before. So the important point is we have to see our data. It has to be separated out and looked at specifically in order to find out the fact that we weren't doing well in terms of breast cancer survival. And so I collaborated then with my folks at the National Cancer Institute, this project led by Dr. Shields and Friedman and Vo. And prior to this study in the early 2020s, it was always the Black individuals that were always cited as having the highest mortality for the young population. But for the first time, we included the Pacifica data. And again, this theme over and over again, that young people in the United States dying at the highest rates of not just COVID, but now also cancer, right, are the Pacifica community. And this doesn't seem like new news for many of us in the Pacifica community. But what this data then shows us when it's published is it's kind of our ticket into advocacy and policy reform and finding funding and allocating resources to younger members of our community who might be more at need. And so we've published this in other studies as well, looking at things like, for the young population at least, late stage of diagnosis is really associated with the Black community across all of these different cancers. But there aren't very many cancers, at least in this study of adolescent and young adults that we published, that showed late stage at diagnosis, meaning like they're maybe even metastatic at the start of the disease, which is obviously harder to treat. But when we look beyond the stage of diagnosis and we just look at the overall mortality, you know, the death rates, we found that across these different cancers for adolescent and young adults, that these are young patients again. They're dying at a higher rate. So regardless of whether or not they're even diagnosed at late stages, like the Black population, even if they're diagnosed not more likely than in late stages, they're still dying. So I think Dr. Mori's research that she's been working on is really key to see that it's important to do the screening, but also there might be other reasons why our populations are more risk at dying. And so, again, young patients should be able to live more than 10 years. These are like people my age or younger, like 30s. They should live more than 10 years. But what we see is that across all the different cancers, when you compare the highest or the best survival to the worst survival gaps are always within the Pacific Islander community for when it comes to these young adolescent and young adult patients. And so why does this happen, right? I had an auntie, she had breast cancer. She was diagnosed younger than me. She's Native Hawaiian. And then she ended up dying, a few years older than I am now, actually. But, what we look at is things like the time to treatment. And so we already know that if there's delays to care between the surgery and the radiation, then that can lead potentially to worse survival outcomes. And that's exactly what we saw here. Was that when we looked at the time to treatment differences, we found that for patients with breast cancer in this paper, there were significantly longer times to get from surgery to radiation. And so if our members of our community don't have access to the radiation, or they are hesitant to do radiation, or they put off the radiation, or they're just busy with life and can't get to a radiation oncologist, like one of my colleagues, then it's important to know that these are important parts of cancer treatment, and we need to do a better job as the doctors to communicate to our Pacifica community. So I'm a radiation oncologist, so I treat patients with radiation, which sounds very scary to some folks. I've had multiple members of my lab, Samoan and Pacific Islander, who've talked to Samoan patients specifically and in the clinic and had to spend, this is actual stories that they told me about how even getting a CT scan or even radiation, the radiation concept is sometimes, whether it's just because it's not natural, whether it's because of historical trauma with proximity to things like atomic bomb testing in the Pacific, including in the Marshall Islands. There's a lot of different reasons why radiation is scary, but what I think is more scary is that when the doctors are telling them you have this life-saving treatment called radiation, what we looked at in the data is across the country, who's the most likely to refuse radiation therapy treatment when directed by a physician and recommended by a physician. It was the Pacific Islanders. And it's not even just, overall, it's especially in the most recent years, this is a trend that's continuing to happen where for some reason Pacific Islanders are afraid of the cancer treatments or refusing cancer treatments for whatever reason. And so we have to do a better job as the radiation doctors to explain why it's, they're going to be okay, we'll get them through it. And the alternative of not treating would be much worse than getting the radiation and potentially going for the cure of the cancer.
Cool. Really important stuff. But in respect to the other panelists, do you mind if we figure out how to wrap up in a minute?
Yep, I want to wrap up right now. The last thing is clinical trials. Important to establish care. It's important to know that if we're not included in the clinical trial, how do we even know that the studies are going to apply to our communities? We don't have a lot of patients who are Pacific Islander on these trials. There were none in cancer trials of prostate cancer. In California, we have the opportunity to enroll patients in trials. At UCLA, there's been only like a couple of patients. This is data that I just got from UCLA. There's only been a couple of patients in the past few years who are Pacific Islander. But the important point is while the representation is low, even just a couple of patients will do a really big jump in terms of our proper representation. So I really want to just at least just stress that the inclusion of people who are Samoan and other Pacific Islander should really think seriously about these trials so they can be included in clinical trials. And then the last thing I'll say is, things like head and neck cancer. We found things like screening within the Samoan community. We don't test because this is for the predominant populations don't have things like EBV, which is a type of virus that causes a cancer. But what we found is that we could significantly potentially reduce the number of deaths that occur due to these head and neck cancers if we were able to implement things like screening. And so clinical trials in the future rely on the inclusion of patients who are, especially Samoan, in the context of these cancers. And if we could do a trial in the future to do some screening, we could potentially save some lives. And
that's a great place to end.
Yeah.
Because I will tell you, we will be tasked to do those screening things in the community. They are rip-roaring to go. They just don't have an infrastructure to really there's no vehicle right now to kind of get them into clinical trials. But like you said, we have to lay the foundation first in increasing their trust. Because right now the IV tower still exists. Yeah. I think because we have some time limitations for the next panel, we're just going to go straight into our next panel. But I do want to preface that by saying, I know Brittany and Kiko, we kind of have a paper brewing with this. I recommend we come and do a spotlight focus, and so Kiko can go through the whole entirety of his presentation, because I want to hear it again. But I think this topic in and of itself deserves a spotlight focus, especially because the numbers are so damning. And I will tell you, Brittany gave you some of the data. There's a whole truckload of data that's not great. And the rest of Kiko's presentation is chock filled with stuff that can only help us. Andy and I are working on some things as well with Samoan Flag Day. I would like Andy to come back as well, do a spotlight focus on mental health and substance abuse. And then we were going to try to deal with diabetes, but I'm going to save that. I'll cue the presentation for my family so it doesn't go to waste. So Naki at the family reunion, I'll put up the diabetes presentation. And so why don't we go straight? Thank you so much, Andy, so much, Brittany, and Kikoa for joining us. I really, really have a heartfelt gratitude for all of you joining us today. It means a lot to me personally, and I look forward to working with everybody in the future soon. All right, Naki, Carl, shall we go into our next panel?
Yes, we will. Let me just thank you, Andy.
Always good to start with the experts to give us a perspective on how important it is. So our next panel is our sector experts panel. And now it is time to introduce Laufo Jake Fitise Manu Jr., who was born in Aotearoa, New Zealand, and raised in Hawaii and Utah. Jake is the oldest of 8 children raised by Karen Dang of Kaimuki, Oahu, and Wailuku, Maui, Hawaii. And Sawanga Jacob Fitise Manu of Kalifa, Upolu, Safune, Savai'i, Samoa. Jake studies social sciences and public health at Westminster University and is pursuing a doctoral degree at Johns Hopkins University. Before his current role as Community Health Program Manager for Intermountain Health, he led public health programs at the Utah Department of Health for 9 years. He was appointed by President Obama to the President's Advisory Commission on Asian Americans and Pacific Islanders in 2015 and served on the U.S. Census National Advisory Committee for 2 terms. He's an advisor for the National Academy of Medicine, Culture of Health Program, and the University of Utah School of Dentistry. He lives with his wife, Lucia, and their 2 daughters in West Valley City, where he served 7 years on the city council prior to being elected to the Utah House of Representatives in 2025. Welcome, Jake.
Talofa, good to be here.
So Jake, we're going to go straight into your present. Oh no, sorry, Naki. I think.
Yeah, let's introduce the other panelists, and then we'll go into Jake's slides, if that's okay. We have Maripa T. Gadanet, is the Associate Dean and Professor at the University of Hawaii at Manoa's Thompson School of Social Work and Public Health. Her scholarship and research focus on the experiences of Native Hawaiians and Pacific Islanders within various systems, including the criminal justice system, juvenile justice, child welfare, and healthcare systems. Her work emphasizes the importance of recognizing and strengthening cultural relevant practices and services for NHPIs. She has collaborated with selected state of Hawaii departments and NHPI communities on numerous projects aimed at improving health and well-being outcomes for NHPI youth, particularly those impacted by the juvenile justice and child welfare systems, substance use, and mental health challenges. Welcome.
And rounding out our sector experts panel is Dr. Victor Thompson. He is the founder and president of NPIEN since its beginning in 2001. Dr. Thompson was born in Long Beach, California, son of Victor and Desma Thompson of American Samoa. He earned a bachelor's degree at Brigham Young University, majoring in Spanish and English as a second language, a master's degree in educational administration from California State University, Los Angeles, and a doctorate degree in institutional management from Pepperdine University. He retired from the field of education after 36 years in January of 2021 as director of the Division of Student Support Services for the Los Angeles County Office of Education. He served as a central office administrator, high school teacher, track and cross country coach, assistant principal, and principal. He's a former adjunct professor for the University of Phoenix and a current adjunct professor for Brigham Young University, Idaho. He has served as a state board member for the Association of California School Administration and also as ACSA Region 14 president. He was the Southern Section president of the California Association of Supervisors of Child Welfare and Attendance. He's the past president of the Long Beach Stake of the Church of Jesus Christ of Latter-day Saints. He was the City of Lakewood's Volunteer of the Year in 2016 and 2017. Welcome, Doctor.
So this panel doesn't have any slides. We're mainly discussing, and we have some very in-depth questions for you, this panel, to kind of discuss. And thank you for. I will tell you that it takes a lot of effort to shorten the bios of these individuals because their resume and CV is longer than my whole body. And so I appreciate that effort. And thank you for understanding the assignment. You guys already put your parents and villages down already. We'll start with Representative Fitisemano. Jake, what do you think about the healthcare system and Samoans utilizing the healthcare system that contributes to these statistics that you just heard?
Thank you for the question, Dr. Samoa. And it's a pleasure for me to be here with this esteemed panel. You know, I think to the core of the question, I am more inclined to say that it's not an issue necessarily of access and affordability. That is a big issue, but that's not the only issue. I do think it is more of a familiarity and a trust issue. I think that we could all probably think about a clinic or a hospital that is within a reasonable driving distance of our own homes. And yet how many times do we frequently push off getting a consultation or getting a checkup and maybe not even accessing services that do happen to be around us. Although I do acknowledge that, yes, affordability and access in terms of health insurance coverage are definitely huge issues and barriers as well that contribute to the disparities that have been talked about this morning. But I still feel, even in some second, maybe even third generation American families, that we still have not developed a culture where it becomes the norm and it is a habit and it is our first response to go in and get regular checkups and preventive care. A lot of times we only go when it's an urgent situation or maybe a late stage diagnosis type situation. And that is definitely a socio-cultural, there are socio-cultural dynamics to that because our people are smart. We do understand science. We do know that medical professionals can provide help and we understand that there is, physiological and pharmaceutical help and all of these things. It's not that we don't understand that. It's not that we're not smart enough to understand that those things are helpful and can help to cure and heal individuals and communities. It's not that. I think we still have a reticence or hesitancy to seek out that care, either because we're not comfortable or made to feel welcome in those spaces, or because that simply isn't how we grew up. We're just not used to it. It's not a familiar thing that's become customary for us.
100% agree. I think there's a paper, it's a pretty old one, that talks about Polynesian perspectives on health. And they talk about how the older generation, maybe first generation, has this perspective of health that is based in their relationship with God, their family, their community, that somehow health is related to that. And that younger generations have more of a biomedical model of health that is, kind of the more Western view of it. But when coming to make decisions, even though they have this like biomedical, understanding, they still revert back to, they counsel people who have that belief of it being more relationship, and so that kind of fits with exactly with what you're talking about, where people will tell them, like their doctor will prescribe metformin and they'll come ask me and they're like, should I take this? And it's like, didn't your doctor say you should? And they're like, well, my friends and my family says I shouldn't. And then I'm like, well, your friends and family have gout. So I don't know if that's the best resource for you to be getting your medical information, but it is what it is. It's a reality of our families and our communities. The esteemed Dr. Thompson, how does education and the educational system play a role in these statistics? Oh, and congratulations. Did you have a good run today?
Yes, thank you very much. I made it. So.
How far was your run?
It was supposed to be a 5K, but I had to run with the 10-mile group because of this commitment. I didn't run 10 miles, but I got lost. So so I ended up running for about an hour. I don't know, an hour.
Impressive nonetheless. Yeah. So how does education play a role, especially education in, of Samoans and Samoan communities? How are they playing a role in these statistics, if at all?
Yes, thank you very much. And again, my perspective is from a K-12 education standpoint. But one thing that I worked on for much of my career was something called the school attendance review team. Okay. So it was our job at the school to determine why students were absent. And again, some of those students were from our community, Native Hawaiian Pacific Islanders. And I recall we had another program which was called the School Attendance Review Board, where we met in the courthouse. So the district attorney was kind of looking at me because a number of our people were coming through there. And he says, well, why are they here? I says, well, a lot of it has to do again with health. And we do still have one of the highest chronic absenteeism rates in America. And part of that may be related to the students' health, but a big part of it is just staying home and caring for the parents, okay, and their health. So I think once the district attorney understood that, he said, oh, okay. So again, he reached out to them. He says, hello, we're here to help you. What can we do again to help to improve your health and help your student attendance? So I think that is the main thing. Just an emphasis on, again, improving and supporting our health and taking some time to, again, improving our diet and exercise. This would be very good in educating, again, all of our young people, our parents. Lastly, my parents were both in the field of medicine. Interestingly, they both lost their licenses to practice when they came to America. So my dad was a medical doctor. He again became a lab technician, and my mother was a nurse's assistant. But in our family, we had very strict diet, and we had mandatory workout. so my dad said, well, what sport are you going to join? I said, I don't really want to join. Well, I knew I'd get killed in football. I'm too kind of thin. So I took up track and field. So Dad would have us, I'd go to my track practice in high school. And then I had to go to work, but he would not take me in the car. I had to ride my bicycle to work 5 miles and then ride home another 5 miles. And that was on top of track practice. So again, I think as we educate our community, I think it will really help our overall health. And again, once the district attorney and others understood that, they says, well, we want to help. I mean, that's what we want to do. So thank you.
So, that you speak to something that we found out, well, we didn't find out about it, but it was very obvious during COVID, was this gradient. It was this kind of social health gradient where we noticed that individuals with kind of lower income, individuals with less education, were less likely to sort of get the vaccine, but this gradient also exists for almost everything health. So colon cancer screening, mammographies, going to appointments, a lot of the stuff that and Jake was talking about kind of fits along that gradient where, and you're a perfect example where you come from educated parents that had very steady incomes. And so you're able to sort of take it, you're exposed to and influenced to sort of engage in healthier behaviors, which, bodes well when you think of like health prevention. I'm acting like I know anything about public health. I'll leave that to Jake. And so, but it speaks very highly to that. I think that's an important thing that we kind of have to talk about if we're going to try to improve these numbers, which are very drastic. I think that the impetus to have this webinar was because the numbers look really bad. And so that's a good segue as we talk about the sort of social health gradient to kind of go into our next question for Dr. Godine. Mariba, what do you think are the social, cultural, structural factors that kind of contribute to not just these cancer numbers and diabetes numbers, but also to sort of substance abuse like ICE?
Well, thank you.
Oh wait, you know what? I didn't see your parents' name and where they came from in your bio. So could you start with that first?
Okay. Well, Talupa, it is a pleasure to be here, and thank you for inviting me to be a part of this panel. So my parents, briefly, my father is Robert Afoy Godine. He comes from Safue, Falfa, Falealili, Mangiangi in Samoa. And then my mother is Simalama Mailangi Vaimaona from the villages of Lauli'i, Alao, American Samoa, and Ulutongi and Mota'a in Samoa. So those are my parents and where they're from.
So the question again is, what social, cultural, structural factors contribute to these health disparities and in cancer, diabetes, and substance abuse in Samoans?
So I didn't get a study on this, but this is based on the literature. So there's a lot, like what Dr. Subika had mentioned. With regard to ICE, there are a lot of root causes or correlations with meth use, and those include trauma experience of the individual, like for instance, family conflict, domestic violence, even mental health challenges. Sometimes it's used as a way to self-medicate. When somebody is experiencing some kind of episode. Also, families who are involved in child welfare, there is kind of a high correlation of, well, also, there's a high representation of Samoans in the child welfare system. And there's a correlation also of those who are involved in child welfare system, parents who are involved in child welfare system to be substance users. The other thing too is housing instability. Incarceration is also a factor that contributes to ICE, and also chronic health conditions. Again, it's a way to feel better, feel good, self-medicating. With regard to, I think our panelists of researchers have mentioned some really good social, cultural factors that contribute to things like cancer. So before I go on, I think it's been my experience with regard to prevention for our well-being. Samoans, I don't believe, has a focus on prevention. If you think about it, when we go to fofos, it's always because we're experiencing some kind of symptoms. It's never something to prevent something. So preventive care, I don't think is ever part of our discourse or part of the culture. So correct me if I'm wrong, Dr. Thompson or Jake, please correct me if I'm wrong. But I know that prevention has never been something that we focus on, preventing, diseases. So given all of that, I think one of the things that is really important for us to look at is part of the reason is that we don't get prevention services. We go see doctors when we're already diagnosed with diabetes because we're experiencing the symptoms. Same thing with cancer. We don't have preventive services, and it's really kind of sad to see our high rates of cancer. Particularly cancers that are that can be diagnosed early on, like prostate cancer, like breast cancer. We don't go to the doctors until we experience something in our bodies. So those are some of the things that I think is really important. There's also, I think, the mentality that that we don't talk about health until we are experiencing in our families. And Reno, you mentioned something about relationships and how we seek services and how we're looking out for each other. But I'm wondering too, if part of the reason is that how much do we as families kind of look out, and how much do we listen? So in Samoan culture, right, we have like a hierarchy. We got our elders, right, and then we've got our among us, and then we got the children and so forth. We got the parents. But when we tell our parents, let's go, blah, 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 how many of them do listen? Many of them don't. I know that that's true for one of my aunties who passed away from cancer. She refused to go. And that's one of the cases that I think about like regularly, is that as a family member, as her niece, I knew that I had the ability to take her and get at while she was still, like when we saw like a lump in her throat, but I didn't do that because I was too busy doing something. She wouldn't listen to her kids. And I think a lot of that is going on with regard to helping our elders, helping our family members really get the needed help, or getting involved in prevention services like screening. And that's one of the big things. Anyway, so, there's family levels. We have to look at what is going on in the family. We have to look at what's going on in the community, right? Like Jake, you mentioned access to services, that ability to trust what's going on. Of course, the other thing that I want to, I think Dr. I forget, Dr. Tapara, yes. He mentioned something about, oh shoot, that thought just totally went out of my head. Sorry.
No, so we share, it's both our entities. And so I will tell you, like, even with my advice, I would say they listen to me 50% of the time, but I have 50% more influence than a regular doctor, and so, but that's still not like,
but
great
it's a really, so
Yeah.
the other thing too that I think I really would like to kind of stress is some of the things that have worked. And when we look at what happened and how we responded to COVID, like the mobile that was used for screening. Jake, you mentioned that was one of the efforts that were done in Utah, and that was really wonderful because it helped with screening. Those to me were like help with prevention, help with services that they needed to screen early on. So those are some of the things I think, while some of the areas and some of the kind of like correlations to these are can be looked at. Family can be looked at, one's biological, one's individual factors, but community also is a really important realm to look at with regard to responses. How are responding to these? Because it takes literally a village, not just the family, but also the community. Policymakers need to also be involved in this. What are some of the policies to kind of improve services? Like, are we getting the language help that is needed? Because that's another thing too, right, Jake? Why people don't trust, because there's no communication. That communication between you and the provider is kind of disrespectful in many times, right? From the perspective of the patient, particularly when you're an older Samoan, right? You expect certain cultural protocols or cultural or languages or communication styles to occur. So when those things don't occur, they're not coming back. So I think that's a really huge thing, is trust. And how can that be built with providers? Because again, I think those relationships really matter, because for us, we don't want to disappoint. If we have that relationship with the doctor where I don't want to disappoint him, I don't want him to think that I'm blah, 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 what are the chances that they will continue to get preventive care, to see their doctors on a regular basis? So anyway, I'm all over the place, but yeah.
No, all true. That kind of goes with what Victor was talking about with the DA, or the low, the poor attendance rates, and how you need community informed health policy to do something effective. You mentioned something about how we don't make this common topic. This is not a common thing that Samoan communities and Samoan families talk about. I 100% agree, but I don't think it's culturally based. Like I've had several conversations about how language and some of our cultural sort of like references speak to the fact that health is very much valued. Jake, can you sort of describe some examples of how? Because what I really think is that when we accepted the perspective of health from the Western view, is that we also accept the common man's perspective of health, which then makes you kind of alienated from it. But in actuality, there's so many examples in our culture of how health is a priority, through our language and through sort of like other types of practices. Jake, you want, and Maripa and Victor, please weigh in as well. But I know I've spoken to Jake about it before.
Yeah, and maybe just to start it off for my fellow panelists to jump in on and add on to, but I think the definition between Western clinical health and our indigenous Samoan or Pacific Islander worldview are different enough that that is a barrier in itself. How do we translate the word health? We say, the general definition or term that's used is soifua maloloina. Well, if you translate soifua maloloina as a rested or balanced or a life that is rested and in harmony, that has nothing to do with eating well and balancing your diet. It has, in the definition itself, right? The literal definition doesn't talk about exercising every day, doesn't talk about watching your, glycemic index and all these other things. It's talking about a balanced, whole wellness, viewpoint. And so those things need to be reconciled for sure. And as others have brought up on this call, this the term we come up in sociology, the term we use is fatalism. I tend to hear that in the conversations with my family a lot. This is just God's will that so-and-so has cancer. There's a lesson that needs to be learned from it. This family is going to grow in their faith because of it, etc. And that, while beautiful in some contexts, removes the incentive for preventive care. It removes the incentive, or there's not even a thought about why should we be preventing or mitigating this if this is the course that my life is supposed to take, if this is what the Lord wants me and my family to experience. And so these are all very tricky, but very real dynamics that come into play when we're talking about health and wellness and clinical care, and the interplay or interface with our religious beliefs and our cultural beliefs. And I wish I had all the answers, but I'll leave that to my fellow panelists to weigh in for that.
Can I add?
I thought you were going to say Menga Maua,
Can I add? I just remembered one of the things I think that is really important, and Dr. Tapara did mention it, is regarding the so cancer treatment. When you hear cancer treatment, like what is it? What are the two cancer treatment? Chemo and radiation.
Yeah.
So it's known to be one of the most painful, discomfort, wanting to die type of treatment. So when education and information about treatment is passed on that way, not by professionals, but by those who have experienced it, that's also a deterrence.
Yeah.
So it's something to think about, because I know that there are educational information regarding the need to seek treatment, especially with cancer. When we're talking about the effects of kind of like the side effects of these treatments, they're not very they're encouraging. They're not encouraging. Yeah, they're severe, but and also depends on one's age, right? Whether or not they, and that's also, if we look at the completion of these treatments, they usually drop out because of the intensity of the treatment. So, and these are experiences of people that are passed on. And so that also information is challenged by, you need to get treatment, blah, 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 because your chances of living and blah, 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 right? And so that's one of the things I think is really important to consider when education, when outreach is being done. It's that kind of information, especially with cancer.
Yeah, I'll tell you, I work in a cancer hospital. I'll tell you some heartbreaking things that I see with Samoan patients. One is the inability to translate context. like you said, Marie, but like, a lot of times you can decrease doses, you can do something to help mitigate some of those side effects. But, when you're talking to somebody who doesn't really understand that, and you're talking to a translator, to them, it's all or nothing, right? Like there is no kind of like doing stuff to minimize the side effects. It's like all or nothing. The other thing that is also heartbreaking is when people kind of refuse treatment because, like Jake said, they're, and you're like, so they go and fulfill, right? Or they use the famu'u, and you're like, it's heartbreaking because you're like, and the saddest part about it too is it's people who understand, who have some kind of like understanding of biology, and so I think the kind of conversations you're talking, the kind of reformation that we need to help sort of address these really stark disparities require kind of this really in-depth look at how we address health in our communities, and we have to do it from a Samoan standpoint, as Jake was saying, like trying to do this from a Western standpoint where we do standard education, where we do standard outreach is not working. They have these awareness programs all over the place. It's not penetrating, and so we have to kind of find better ways to do this. I want to thank this panel so much. I thank you so much for your time. I know we ran over like a lot. So and thank you so much for giving us your time, your talent, to talk about something that is so personal to all of us. Yeah.
Yep, definitely. Thank you to the panel. Have a great rest of your weekend. All right. So those are our sector experts. Great points of view. We're going to get to our community leaders, our final panel. And I am going to start with our pastor. And then go through the rest of the panel. So our pastor, Reverend Pausa Kaio Thompson, is a Samoan clergy activist and theologian, which is secondary to his role as husband to wife Maylin and father to their 4 daughters, Daisy, Asenati, Fonoa, and AJ. He's an alum of the Kananafo Theological Seminary in American Samoa and holds master's degrees from Union Theological Seminary in the city of New York and Boston University in Massachusetts. He is currently a PhD student with an emphasis on comparative theology and philosophy at Claremont School of Theology in Claremont, California. He's also a senior pastor of the Malama Lama Fo Samoan American Ministries Church in Long Beach. His scholarly work accentuates the theological discourse, indigenous culture, and wisdom and social justice issues of Samoa and Samoans in diaspora. His ministry encourages people to be change agents in the world by invoking a more socially conscious ethic of Christian practice. Welcome, Pastor.
Hi, guys. Thank you so much. Thanks for having me.
The next member of our community leaders panel is Natalie Asun. Natalie Tualemoso Asun serves on the RAMS executive team as Director of Community Engagement and Government Relations. Natalie shaped and launched transformative, first-of-their-kind initiatives that reimagine what community mental health can look like. Across San Francisco and Alameda counties, she's helped build pathways of care through trusted partnership with community-based organizations, bringing forward culturally responsive initiatives such as the Samoan Wellness Initiative, Filipino Mental Wellness Initiative in San Francisco, the Southeast Asian Mental Health Initiative, the SF Pacific Pacific Islander Wellness Initiative, and Kendezi Black Perinatal Wellness. Her work has expanded not just access to care, but the very definition of what care can be. She co-founded and co-convened the first Pacific Islander Clinicians Group and the Southeast Asian Clinicians Group. As interim director and co-founder of the Regional Pacific Islander Task Force, Natalie continues to lead a movement grounded in visibility, dignity, and collective strength, ensuring that Pacific Islander communities are not only seen in data, but honored in their full humanity, resilience, and voice. A proud daughter of American Samoa, fluent in Samoan, and deeply shaped by her heritage, Natalie carries her culture not only as an accessory to her work, but as its foundation. Her academic journey through San Jose State University and San Francisco State University further sharpened a lifelong commitment to public health, justice, and community empowerment. Welcome, Natalie.
Talofa malo sifu manuia.
And next we have Manu Malo Ala Ilima. Malo is Fatane, a Samoan trans man with 25 plus years of nonprofit leadership. Formerly with Utopia PDX and the American Red Cross, he leads Pacifica Impact LLC, specializing in DEI and organizational development. As Pacifica Transgender Men Network president, he fosters safe spaces for Pacifica Indigenous transmasculine communities. Welcome, Malo.
Talofa. Thank you, Carl.
You're welcome. And then we have Tana Lupule. Lupule is the director of Native Hawaiian Pacific Islander NHPI outreach at Asian Pacific Partners for Empowerment, Advocacy, and Leadership, APPEAL, a national nonprofit organization created in 1994 to advance health, justice issues for Native Hawaiians and Pacific Islanders and Asian Americans. Tana has more than 25 years of experience in community service, including cross-cultural leadership, capacity building, community-based participatory research, and policy change. Welcome, Tana.
Okay, hi, everybody. Happy Samoan Language Week. I just want to thank you so much for your patience. I know we're like way over. And we had a ridiculous amount of technical difficulties trying to get this started, but we did it. We did it. You know, if that will be done, it's going to be done, right? So you guys were able to hear kind of all the presentations, but even more so, I think you guys lay witness to these numbers in real life, right? I think the Reverend and I had talked about these health priorities, you know, back in November. And so these priorities, you know, we experienced it as a community way before these guys presented it. So hence why I think it's really, really important that we get your perspective on how we move forward. We knew this was happening. We just have data now to say it. And so I do want to, this is a group that I would love to hang out personally. So I do want to make sure we touch everyone. So I'm going to ask a question and then I'll just have everyone's feedback. So we'll start with ICE. How has crystal meth use affected Samoan individuals, families, and communities in California? Since Tana, you're at the top of my view list, let's start with you.
Yeah, thank you so much. An honor to be here. And I didn't get to recognize my parents, the late Reverend Sepulona Atafalepule, Vailo and Leone, the late Talo Lepule from Afongo and Selaimua. To me, the drug epidemic, no matter what drug it is, I know we talked about meth, it just hits like all communities, right? I think that's something we have in common, but how do we balance that with the cultural support system? And I think it can lead towards what I've heard is called personalized medicine. So similar to whether it's education or solutions in supporting our communities that face these challenges, personalized medicine versus the traditional, which I've heard from some previous panels too, is going to be key in providing some solutions. And that is still to be built. But yeah, it's definitely an epidemic. We see, and I'm sure we're all facing the same in regards to like family members who are going through it, and the struggles of like, how do we measure our love in support of somebody who has an addiction, right? So that's a hard thing. So thank you.
Natalie, do you mind mentioning your parents and where they're from? And then the question is, how has ICE use affected Samoan individuals, families, and communities in California?
Yeah, so Tailava Mole Nea Vanua. Yeah, I am Natalie Tolimoso Asun. Both of my parents are hail from the big island of Manua. That is Faleasau Manua, Ofu and Osenga Manua. That is the Tofaya Tolimoso Mutangi Asun and Katerina Bine Tolimoso Asun. And thank you so much for having me on this panel. You know, I came into this work as a public health practitioner, and then now I'm in the mental health work. And perhaps I was naive to know that, to learn, I was naive to learn that there was such a humongous drug problem among our community. And, you know, and a few things I've learned along the way is that addiction is rarely like a first problem. It's usually a problem that comes up, you know, as a means to cope, or, you know, there's a need for it to mitigate an issue. And in the work that we're doing here in the Bay Area around prevention and early intervention in mental health, when we designed these programs, we knew that we had to hold an element of a culture, you know, like it has to come from strength-based. Like how do we get to work with our community in a way that they respond to? So and this is also where growing up in Samoa and understanding speak Samoan fluently, understand the, many elements of our culture, that came in handy in creating programs that, I want to use Dr. Nia Itaota's words here, programs that appeal to the heart and soul of our community. As we, in the years that we have doing prevention, early intervention, mental health work here in the Bay Area, we are seeing a lot more of our community members coming in for, drug addiction. And, and moving into the next years of our program, also focusing on how do we incorporate and bring that piece of the work into what we do. And that also includes like who are providers that can help us, provide such service. And I just want to quickly mention, I came across more recently one of our own Samoan gentlemen who facilitates and leads the Men on the Way. Oh my goodness, and I'm Carl Matavao or Tangobao, I believe that's his name. So there's a lot of work to be done, but I feel like the strengths and assets of our culture and the language, can help mitigate some of the growing meth addictions.
Thanks, Natalie. We'll go next to Manumalo. Happy Pride Month. Don't forget, you're pretty good at mentioning your parents, so please start your introduction there, and then we'll go right into your answer. Once again, how ICE is affecting Samoan individuals, families, communities in California.
Yeah, Lava Mole Avanoa, Dr. Samoa. My father is 90 years old, and he is Lesusunga Papali Itele Betoni Ala Ilima, and we hail from Faleu Monono, Sapapali'i Savai, Salani Falealili, and Fasito'o Uta Upolu. And my late mother is the Seta Afionga Velenga Tuitele, and we hail from Ofu Manua, Amanave Tutuila, Leone Tutuila, and also Fasito'outa Upolu. And now for your question. Very grateful to be on this panel. I had some time to think about it. And, you know, what both Tana and Natalie mentioned are really critical in not just processing this information, this reality that we have a epidemic of strong drug use within our community. And what I noticed before, we would send, you know, our sons and daughters that had this problem somewhere else to stay with relatives back in America Samoa and Samoa. But as you probably know, they also have a meth problem. So I think tackling this issue and owning it ourselves, this is our family members, it's not someone else's problem, I think is a start. That we look after our own and not leave them abandoned somewhere dealing with this drug issue. And that's what I want to initially say about it right now, because I have some other ideas for later on.
Sounds good. So that takes us to the Rev. Please mention your parents, where they're from. Also, you know, Manamalo brought up something interesting about sort of the ICE epidemic back home. So a real quick question when you answer this one is, do you think it started back home, came here, or do you think it started here, going back home?
Well, first of all, talofa malolo soifua mane langim mamai lenei tulauleaso. My parents are from all over Samoa. Samoa atoa. From the kingdom, ioi le manuatele, iofu manua, o auno'u, ia, o Nu'utina, sa mai whangasa, o aua, Waitongi, ia, e voina ia ai I Sosolo. Yeah, I want to mention my wife too. My wife is from the village of Nofoali'i, yeah, and Salwafata, because she's sitting right next to me. So, but the question, I don't really know if I can answer that question, Ray. I mean, here's what I will say about the epidemic that we're faced right now. First thing I want to say is, I think the way that our people view this whole epidemic, I think we're using the wrong lens when we view it. You know, back in Samoa, you go to the doctor to diagnose. We don't see it in Samoa as a sickness. And I think that's part of the issue right now with how it's spreading, is because it's kind of shunned. You know, it's a form of disgrace, and a lot of folks who are addicted are chased out into the streets to not be seen. But I don't think the government, I don't think the nonprofits that are there right now are using the right methods to attack the issue. And I'm not totally sure about where it comes from. I will say this, that a lot of this stuff is not, you know, it's not a local thing. It's coming from off island. And the problem is, it's our own people. It's our own people that are contributing to the demise of our next generation. And so I'll just leave it at that. I know a lot of folks have a lot to say about that, but that's my perspective on that.
Yeah, that's the after hours question.
Yeah.
Right. That's really interesting that you frame it like that, because one of the things I found very interesting is our view on schizophrenia and our view on crystal meth use. You know, with schizophrenia, we're very compassionate. You know, El Valle, right? We actually welcome. You know, we feed them, we let them kind of wander through without much hassle. You know, and it doesn't even matter. Like, you start to know who the Valle is from a different village. You know, and just let them go through. And yet, when we talk about ice use, it becomes a completely different animal. You know, it's very looked down upon. It's a shame on the family, the village, and yet, they're both conditions. They're both like medical conditions that require treatment. And so I agree 100% with you, putting this into our lens. But I think that's a metaphor for everything else we're going to talk about. Is we need to put cancer disparities, we need to put diabetes disparities into our lens, which means the movement needs to come from inside. It's COVID taught me that waiting for someone else to save us is never going to happen. And so you build the car from the inside out. And so that's our next question, right? Is how can community organizations, churches, families, healthcare systems work together to improve these health outcomes because they're bad? I keep saying it, but because it's true. You just saw our cancer disparities. I don't even have to tell you about diabetes disparities because we see it so much now, like ICUs. So the question going forward again is, how do our community organizations, churches, families, healthcare systems work together to improve these healthcare outcomes? Yeah. So we're going to go backwards this time. We're going to start with the Reverend and then go back towards Tana.
Yeah, I like what on the last panel what Jake had said about sort of this idea of fatalism, right? And that was one of the sort of intentional methods that I had used during COVID, is to kind of use the pulpit to kind of dismantle some of that thinking, about that time frame and COVID. But I use myself as an example, and because that's the only way that I know how to do it, is just kind of not be confined to one's own position in the community, especially if you're looked at as a community leader. If I'm a whaiwhiau, then I need to be in the community. The literal meaning of the word is e te alu e whaiwhiau o tangata, e te whai ma'auauna I tangata. So people, I think a lot of pastors, whaiwhiaus these days, and this always gets me in trouble with the main church, and what I mean, I'm always in trouble. So but I'm okay with that. But it really just, for me as a person of faith, it's just taking it back to the original discourse of what it means for me in the Christian faith. Jesus is, you go out to the people and you serve them and you be amongst them. You be amongst the sick. You be amongst the poor and the hungry. And so that really is, and I get inspired all the time by folks who are constantly in the community. You have all of them who are here in the other panels as well. And I can learn a lot as a pastor from the folks who are, who have boots on the ground in their own avenues and their own sort of fields of expertise. So that's my 2 cents.
Very interesting. Marmalo.
Yeah, thank you for the question. I think, as what was mentioned, utilizing existing systems like our culturally specific faith-based groups or churches, culturally specific community-based organizations or CBOs, they have a huge task, right? Because they are the hubs for a lot of our people, our families. They either attend church or are connected, with a CBO that's trusted. And that was something that was brought up earlier as well. And then how do we help these two specific entities that work with our people directly? I was just thinking, as I heard the other panels, what would be super beautiful, since we have access to technology, is probably develop something that we talked about during COVID, but actually do it, is have like an app that is not only nationwide for NHPI, Pacifica folks, but then you're able to toggle between Pacifica cultures. Like if I speak Tongan, all I have to do is like toggle Tongan and everything is in my Tongan language that deals with like SDOH, social determinants of health issues. Um, and but that would help individuals, whether you're in California or in Oregon or in Utah, find each other. Uh, and like kind of list things per county, per state, like where can I get mental health care, for free, or free screenings, for cancer, um, food security locations. I think if we developed an app like that that was user friendly, that had the ability to translate it into our own native language, would be super helpful. I don't know how to do it, but I just had that idea. So I'll pass this on to Natalie.
Right.
Dr. Samoa koe whaasaua ka fsiri whamamole.
What can community-based organization, or how can community-based organizations, churches, families, healthcare systems, how can they work together to improve the health outcomes?
I think we live in a world that's full of information, so I think there's information overload. I think we've also, and maybe because I've also been in the work for so long, I feel like, oh, we've been raising awareness for so long, so what is that next thing, right? So, and that next thing for me is, systems alignment, the system in which we, in terms of, okay, we inform our community, these are the things that you need to, early screening save lives. And then we say, okay, then we're going to, you have to go to this hospital or this clinic for your appointment. And then we schedule the appointment, but, either they don't make the appointment or for some reason they went there and the interaction or in the facing with the clinic, was not pleasant. So they left. So so there is like that information, like what do we do with information that raise awareness? Absolutely, it informs people about what needs to be done, and then what is that next action item. But we need to also create those relationships that activate the awareness that's been raised. I know this happened during COVID, and we brought the health systems to the community. So I know that we here in the Bay Area, we invited community health centers and screening and vaccination clinics to the churches instead of having our folks go to the clinics. So I know that bringing the health system to our community where folks are most comfortable, it has been, instrumental during the COVID time. I also believe that leveraging what's already good. We have a lot of our churches, that I think most times, so how do, what else could we bring into our churches that can help with reaching the community, whether that's food resources or health information? So leveraging what's good and bringing the goods to the community, and and our community-based organizations, build up their capacity to be that resource to the folks that need it most, and they're the closest to the community. So build up their capacity, fund them, with more funding.
Yeah, you bring up a good topic about how we communicate in our community. How do we act upon information we're given, but also how do we give that information to each other? Yeah. And there's much to be said about how we do that in the Western world. We had these community halls that we call talanoa sessions. But that's not always the way we effectively communicate, right? And so, the cutie pies have been using a method called Faikala, because just like the FICA podcast, we tend to give each other more like pertinent, personalized information when it's just you, you know, um, gossiping with your family or your friends. But the problem is when I eavesdrop, I don't hear any topic about health. I'm like, if I feel only ikili pekala imea maloloina, like how come where's the health information that you're supposed to pass to each other? And so that brings us to Tana. Tana, what I look forward to hearing your response.
Oh man, so I'm just dying to get on, but I'm gonna have to start off with a pardon and to lava to my elders and Pastor Thompson. But we also live in a world full of shit, right?
Yeah.
And so how do we balance that? How do we balance cultural ways to the westernized ways, as it was brought up not only with this panel but previous panels? There's a quote that I remember is we don't have to westernize in order to modernize. So we don't have to westernize in order to modernize, but how do we do that? It has to be a balance, right? And I think some of that was shared here. I mentioned earlier personalized medicine versus traditional one size fits all. Well, how about we lean towards personalized intervention versus traditional one size fits all? And Pastor, I get it because I've been sassed on my journey too, but it's going to take some brave steps from us as as a collective, from this beautiful webinar you have today with researchers, community leaders, faith-based. It's going to be that whole, and I'll give examples like for our communities who say, oh, it's God's calling, I'm going back home. Well, I've learned to counter that with the same faith belief in saying, well, God also created the mammogram, so we have to be creative in responding to that fatalism approach that we have. So that's like using the PK as myself, a preacher's kid myself, trying to just be creative in that sense. In regards to our young adults, we're putting together a Pacifica Picopolo tournament, and that's a way of really addressing kind of the health and well-being of our communities without saying health and well-being. We're just saying like, let's come out and play. So again, kind of personalizing our interventions without really saying like, oh, come to a mental health workshop. Like, how about come to just a FICA podcast? Let's chat and talk story there. I think it's going to take a collective effort, right? From data disaggregation efforts, research, advocacy, and education to the multiple levels such as funders, legislators, state, local, and federal, to our communities, to our local health departments. So I really love the three panels that you have here, because I think it's starting to model what we need as far as addressing solutions and tailoring them, because one size is not going to fit all. Maybe the Samoans in Northern California, a different intervention versus Samoans in Southern California. So I think it's going to be, Manuelo mentioned social determinants of health. Well, why don't we just reframe that into like, it's my world, this is what I have to live with. And how do we leverage faith-based? How do we leverage educators? How do we leverage legislators? So sorry for the little soapbox moment, but
Oh no,
I'll sign off.
get on your soapbox. This is the time. Okay, we're going to kind of do a speed round. So our next question is, if you could recommend one action for community members and one action for policymakers to reduce health disparities among Samoans, what would that be? One more time. If you could recommend one action for community members and one action for policymakers to reduce health disparities among Samoans, what would that be? We'll start with Natalie.
Well, we can begin by, really just access to what's available, right? And if you are hesitating to access the services that are available to you and the resources that are available to you, there's already a good number. And I speak from us here in the Bay Area. There's a good number of resources, community-based organizations that are around, or community leaders reach out to them, reach out to them and ask for help, and I said many. So if one says, oh, reach out to another one. I think our community is so prideful, like, blah, 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 right? There's like also that pride where it's like, oh, the service is there, like come and access the service, and sometimes a little like, okay, let's have an open house and invite the community to come and see what we offer. And in terms of policymakers, really just listen. You cannot innovate or you cannot introduce a policy if you don't understand the people you're trying to create the policy for. I think the voice and the perspective of community members whose health issue or whatever the concern may be that needs to be addressed or uplifted and elevated, they need to be part of that conversation. So, that civic engagement. So I think that's the other part with our folks. It's just like, yeah, fight. I think a lot about that. Like for us growing up, like we have our makais, right? And fight like all the decision making. So we trust them enough. And I know it's like can be a whole conversation too. Maybe some of them are like, hey, we don't trust our makai. But that's our belief. Like that's the system we grew up in. Like, okay, if I owe him the person that leads our family. So we trust you to lead us. And that's also how we see systems. Like, okay, when I go see the doctor, I'm going to trust you to tell me what's best for me or otherwise. And that leaves us also vulnerable because we don't say, oh, so I think, there's a lot. It's okay to also say to the doctor, oh, I don't want to be on that medication because I'm going to go, be like Dr. Thompson and run as many miles as possible, right? So, and I'll just leave it there. Thank you.
I know. I often ask that too. It's like, how many if I so California? They're like, why? I'm like, because you're there. We'll go to Manmalo.
Yeah, thank you for the question. What I think Natalie touched on it perfectly is not just resources, but the access to resources. So what does that mean? What I've been encouraged in seeing in a few CBOs, one in California is that fundraising aspect of having a bingo to generate revenue, to do the projects that we want to see have happen in our community. And I think there's a sense of utilizing the tools that work because we've done it with our church or we've done it with our family. I mean, how many bongesi have we've been asked to fill out, their different squares? But we can always ask for money, but we should also be responsible for generating money as well and not get used to just asking our public partners or public facing partners, to help partner with us, right? I also think maybe even looking to leverage corporate sponsorships if they align with our values and our mission, and stepping outside of our comfort zone, or like even the different Indian casinos that are established throughout California. We're indigenous, so are they. They will be most likely in tune with our cultural values and the way that we live life. So I think, yes, access to resources is important, but also thinking outside the box when it comes to that, which leads to how do we interact with our elected officials and public policymakers. It makes that conversation even easier of not just identifying what the problems are, but seeing that we've done all these other efforts to bring forth the attention and addressing the issues that we want them to put into policy that makes sense for our community. So, yeah, hold our elected officials to account, ask for what's appropriate for us because we're from the community. But also, let's think of different ways to generate revenue for our community.
Tana?
Cool. So, recommendation to our community to drop the politics, drop the community politics. We're our own obstacles before we even get to potential solutions. And for my Christians and believers, like really lean on the question, what would Jesus do? So I'm sorry, I'm bringing up my PK side because that's been a challenge in just my own journey, and I'm sure I'll get sauced for it. But our own community sometimes is the very obstacle that can bridge the two mainstream and cultural ways together. For policy folks, recommendation, I'm a hyphen it because it's actually two. It's going to be support data disaggregation and support earmarked funding for Native Hawaiian and Pacific Islander community. Thank you.
You gonna name some names? Say, don't do that.
That's a different podcast.
Reverend. Reverend, you want to answer a question? It's if you could recommend one action for community members and one action for policymakers to reduce health disparities among Samoans, what would they be?
Sorry, my mic went out. Were you talking to me, Ray?
Yeah. If you could recommend one action for community members and one action for policymakers to reduce health disparities among Samoans, what would they be?
I'm just gonna mirror what Tana said. Just drop the politics, and it's great to to show up in public forums and be in solidarity is one thing, and then behind the closed doors is where the real action happens. And I think, all of the organization, and I speak, on behalf of someone who lives and works and breathes here in Los Angeles, is that we can do better as far as community in the way that we intersect our work. And we, it's like we're all fighting for the same, well, let's just be honest. Funding is one of those things, and a lot of the gatekeeping that happens in community, it's a real thing, especially in our community. And I wish those barriers can be broken down. Let me say this. Why can't others? Why can't, you know what I mean? So my thing is I always try to lead by example and say, listen, break down the barriers of this hierarchy and let's redefine, like for myself, what it means to be a Whaiwhi out. The second thing I want to say, when you mentioned policy, I don't know if I'm blessed or I've been cursed with the task of taking on the Samoan Flag Day LA here, which is going to be celebrating 50 years of the festival, which is in reality it's the very first Pacific Islander festival out here in the U.S. diaspora. I got an interesting email not too long ago from a city representative, policymaker that said, we are unable to support you because our efforts have been redirected in another direction, but we would love to come out to the event and represent the city and speak to your people. So that was an eye-opener for me as part of a grassroots organization, to know that sometimes a lot of our people, we labor for free. And a lot of these policymakers and folks who make the laws know that. And it's because we don't hold them to a higher standard when it comes to our needs in our community. And so that's the one thing that I would say about a lot of the changes in policies. We've got to be a little bit more aggressive with folks to have them see our worth. So yeah.
Right. Name some names. We'll write some letters. Send some angry emails. Okay. Thank you so much for your time, but I want to give you one opportunity to promote anything you guys are doing right now. I know there's a ton of things on the calendar. I just want to give you this opportunity to sort of let everybody know who's going to watch this podcast, what you got coming up this summer that you think the community should know about. We'll start with the Reverend, and then we'll go down.
Yeah, I mean, great way to segue into the Flag Day 50-year anniversary here in Los Angeles, happening August 1st to the 8th. And funny thing that was mentioned, Tana has a great thing going on with the pickleball, and we're doing the same thing, just kind of giving it, reshifting the focus this year as well. We've got some great folks who now taking over the Flag Day alongside with myself, who grew up out here, who know the legacy of the Flag Day. And so we're, really highlighting youth sports, team sports, things like that for the festival. Also, giving great opportunities for folks like Dr. Samoa to come on, for Ray to come on over there and, utilize the spaces where we know that our people congregate. And one of those places is the festival, but also, we run a bingo. And here's the one thing is I have some crazy, I call them predatory insurance folks who come over there, and they offer $50 for people to give their insurance information and then do some kind of crazy testing. But folks flock to that, right? Even if they can just get $50 off. And so I'd like to see more of this, right? Of our folks being there at a bingo hall, right? Because that's where our people are. They're in the churches. They are also in the bingo hall, and probably the casinos as well, Mm-hmm. So, and Flag Day. So, yeah.
Awesome. Yeah, we're going to be doing some health programming, some cancer screening over in Samoan Flag Day. I think our day is August 5th. Yeah. So we'll be down there to join you. Natalie?
May was full of events and activities, and maybe this is every year in May this is new for us to celebrate our high school graduates, and we just held our for Alameda County last week on Friday, and as the years, each year we have even more participation, so we're so proud of that. So our team will be recruiting more of our Alameda County high school graduates for next year. And, I just want to share, we created Pacific Islander specific, Samoan specific prevention, early intervention mental health services here in the Bay Area. Here in Hayward, California, please come down. Even if you are like, oh, I don't know if that's what I need. But come down and and see us and see how we can help and support you. And in San Francisco with the Samoan Wellness Initiative at the Samoan Community Development Center, these creating as many access points as possible so our community can access the services that they need.
Awesome. Thank you, Natalie. Tana?
Yeah, so I mentioned earlier, we have our Pacifica Pickleball tournament, June 27th, the last Saturday of this month. It's going to be in Oceanside, California. The website is www.pacificapickleball.com. Our Instagram is @1pacificapickleball. Thank you.
I'm going to need the profiles of those refs. Manmalo.
Well, as Dr. Samoa mentioned earlier, this is Pride Month, so happy Pride. Something that I've been working together with the Pacifica Trans Men Network is that for mental health well-being, we have closed confidential Talanoa group sessions that we have virtually once a month. And we also have closed confidential writing sessions. So we'll have prompts and we journal or we write a poem or an essay. So from the writing sessions, we actually are developing an anthology for Pacifica men's voices here in the U.S. diaspora. And there's a documentary element to it too. So that will happen towards the end of summer, but we're piecemealing everything together. And it's creating a really safe environment for our Pacifica trans men to thrive.
Thank you so much for all your time this morning. It was the toxic part of me thought we could do this in an hour, and so like true Samoan fashion, we took an hour and we blew it up into an hour and 20 minutes. So thank you so much for your patience. Thank you so much for your wisdom and all your useful thoughts. But even more, I'm grateful for the work that you guys all do to uplift our community and to make sure that tomorrow is always going to be a good day. So we're going to sign off for now. This will probably be a series. Now that I know how much interest and how much stuff we have to do, we'll likely kind of have more of these kind of webinars in the future. Yeah. That's if Carl and Naki let us.
Definitely. What an amazing time spent to hear from all the different segments, but especially the community, because the community is the one, these are the leaders in there day to day dealing with the, boots on the ground where the rubber meets the road kind of thing. So extremely valuable information and time. Thank you to all the panelists, but especially the community panel. Thank you, everybody.
Manuela so Tafa.
Peace, everybody.
How do we turn the live off?
Let's see. All right. So we had it's an amazing time. Thank you, Dr. Samoa, for putting this together. And I think that, to your original point, the need to put this front and center and actually have conversations about it and try to figure out solutions from different angles. To your other point of maybe this becomes something that we do going forward. So there's not a kind of a one and done situation. It's a continued flow of information, because you're right. It seemed like at some point it was like, we need more time, right? We need more time to deliver the message and put some more detail to it. But appreciate you. And it's amazing that you got everybody together on a Saturday to do that. That speaks a lot about you and people believing in when you ask for help, that people say yes and just figure it out after. So
that seems to be our pattern. Yeah.
Yeah, we were talking about it before the show that I can't remember who it was, but somebody said, yeah, I didn't know it was a Saturday, but I was saying, no, we just say yes. And then we figure it out a couple days before.
Just a couple quick announcements. There's an Appeal Leadership and Policy Summit in San Francisco on June 18th to the 11th. There's also the Pacific Islander Clinicians Conference. I think it's the Mental Health Clinicians Conference on October 16, 2026. That's going to be in the Bay Area.
Foster City. At the Crown Plaza in Foster City.
Foster City. And then there's also going to be a Utopia, California event somewhere in September, October that we'll probably put out on our social media.
So look for that on all forms of social media. We will get a hold of those things for the community announcements on the FICA podcast and remind everybody as we get closer. But thank you, Dr. Samoa, so much for getting this important information out to the community.
Thank you, and Nagy, for always being advocates and always showing up. My heart goes out to both of you.
Our pleasure. Thank you, Doctor.